Inflammatory bowel disease, what a pain in the guts. Really, it really is a pain in the guts. There are two main types that we're going to think about today: ulcerative colitis and Crohn's disease. Knowing the difference between these will help you become a pathology superhero. Let's compare and contrast Crohn's disease with ulcerative colitis. Crohn's disease causes inflammation in the terminal ileum in almost all cases, but also patchily through the colon. We call these skip lesions. They're not continuous. In addition, Crohn's disease gives rise to transmural inflammation. The inflammation spreads from the inside through to the outside of the bowel, and this can give rise to deep penetrating ulcers, which leads to fistulas and abscesses. In addition, fat wraps around the bowel, trying to protect it. The transmural inflammation in Crohn's disease also leads to strictures, which can lead to bowel obstruction. In contrast, ulcerative colitis is a continuous inflammation that starts in the rectum and moves backwards around the colon. It doesn't affect the small bowel. It's a disease that only affects the very inner mucosal surface. It erodes it away, leaving the pseudopolyps that we can see illustrated. There are no strictures and no fistulas in ulcerative colitis. Let's emphasize these points. In Crohn's disease, there is transmural involvement of the bowel wall. It becomes thickened, inflexible, and resembles a rubber hose. Radiologically, we can see that the lumen is very narrow when contrast is introduced. This is called the string sign. The inflammation extends to the adjacent mesentery, which becomes thickened, and the regional lymph nodes are enlarged. The illustrations on the right demonstrate a bowel with Crohn's disease. You can see the skip lesion, only part of the bowel is affected. You can see in the bottom microscopic illustration the very deep linear ulcer. Notice how the mucosa has a cobblestone appearance in the top picture. This is due to multiple fissuring ulcers cutting up the mucosa like this and giving it an appearance like an old cobblestone street. The key microscopic feature of Crohn's disease is the granuloma. When you see them, great, we can make a definite diagnosis of Crohn's disease down the microscope, but they're only present in 60% of cases. So in many cases of Crohn's disease, we rely on the other features to diagnose it. So in summary, the bowel complications of Crohn's disease are obstruction from strictures, fistula formation, abscess formation from the deep penetrating ulcers, malabsorption from its erosion of the mucosa in the distal ileum, and also there's a moderate increase of GI carcinoma. Less well known are the extraluminal complaints, the things that happen in Crohn's disease outside the bowel. Perianal fistulas, fever of unknown origin, failure to grow in children because of malabsorption. Arthritis, erythema nodosum, and pyoderma gangrenosum, which are caused by vasculitis, are also associated with Crohn's disease. The immune response can cause iritis, yes, inflammation of the iris in Crohn's disease. Now, all these things can also be found in ulcerative colitis. Sclerosing cholangitis, where you get inflammation of the bile duct, is restricted to ulcerative colitis and isn't found in Crohn's disease. let's think a bit more about ulcerative colitis. Here on the right you can see inflamed bowel that begins at one end and is continuously inflamed until it suddenly stops. It stops becoming red and has a pale colour again. It can involve the entire colon, which we call pancolitis. In a few cases, the terminal ileum gets what we call a backwash ileitis, but predominantly this is a disease of continuous inflammation. The radiograph on the right illustrates the findings that we could see in ulcerative colitis. We get little polyps of residual mucosa left due to the superficial ulceration, and this gives this curious interconnected pattern that we can see on radiology. So in summary, these are the features that ulcerative colitis lacks compared to Crohn's disease. There are no linear fissures, there are no fistulas, and there are no skip lesions. Down the microscope in ulcerative colitis, we see changes in the mucosa only, and what we see is an acute colitis. We see cryptitis. This means inflammation of the base of the glands. These can ulcerate, and we can get micro abscesses, crypt abscesses, just like the granuloma was the key diagnostic feature in Crohn's disease. The crypt abscess is the key diagnostic feature in ulcerative colitis. The most feared complication of ulcerative colitis is colonic carcinoma, and this is greatest in pancolitis. Approximately 30% of people will develop colonic carcinoma with long-standing pancolitis. Where there's minimal involvement, just the left colon for example, the risk is much lower, only about 5%, and it's even lower with rectal involvement. The second complication that can cause death in ulcerative colitis is toxic megacolon. Sounds like a disease for a pathology superhero. What it actually is acute dilation of the colon due to loss of muscle tone in an acute attack of ulcerative colitis. It can cause systemic toxicity and shock and can be a medical and surgical emergency. In this video, we have covered inflammatory bowel disease. We've learned about Crohn's versus ulcerative colitis and the complications of these inflammatory bowel diseases. We've learned how you can be a pathology superhero by detecting and preventing complications. In particular, you have recognized that you can be a pathology superhero.